So for people who've said they will never be on hormone replacement therapy, but you've been using the ring or you've been using birth control, guess what? You've already been on hormone replacement therapy. So in today's episode of Rebranding Menopause podcast, we are here with Dr. Stephanie McNally, and we are going down that rabbit hole. Yes, we are. We're going down hormone replacement therapy in every which way we can. We're actually going to show you the physical hormone replacement therapy prescriptions as well. So let's get into it. Welcome, Dr. McNally, once again.
I love it. Let's talk hormones.
Yes. Let's talk about the black box warning being removed from hormone replacement therapy.
We can't say it enough. 7 times, 7 ways. So when we're talking about the black box warning removed for locally absorbed estrogens, estradiol, which is bioidentical, meaning what your ovaries naturally made, that has been lifted. So whether it's systemic or if it's local, additional hormonal therapy may be needed. I think we're going to get into that a little bit.
Yeah, because I don't think people know what the local systemic, it's confusing.
It's confusing.
Yeah.
So even just to level set, when people talk bioidentical, all that means is that your body is making the exact similarly structured estrogen and progestogen.
Just like if your hormone, your thyroid was low, right? Wouldn't you take
a levothyroxine?
Right.
Correct. It's what your body was naturally making.
Right.
So that's what the bioidentical, it's more of a marketing situation. Bioidentical, estradiol, progesterone. These are what your ovaries made and will continue to make to a certain point of your life.
Okay. So as far as the black box warning being lifted, tell us a little bit about why it was put there in the first place.
The estradiol locally versus systemically are absorbed differently in different doses. So when we're talking about why did this start, black box warnings were really done based on studies done 3 decades ago, really connected to the Women's Health Initiative as a main jumping off point, where women in that study, and we've talked about this, we'll keep talking about it, the average age was about 61. And the outcome was looking at cardiovascular disease. But these women were taking hormone therapy that was not exactly what we were doing now. And there was a hard stop because these women were given a higher risk assessment for things like breast cancer. So they came out and said, do not take hormones, not separating women that were in that early menopausal transition, average age 51, 52, and a woman that was in her 70s. So when it came out and said it's increasing cancer risk, increasing cardiovascular complications, everybody said, stop, 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 not separating systemic from local, not looking at what we're doing today in terms of the hormones versus what we did back then.
Wow. And so also, I think that women that are younger, so the study also says, correct me if I'm wrong, that the earlier you start your hormone replacement therapy, like in perimenopause, just going into menopause, the more successful you'll be. And the more it will protect you from heart attacks, blood clots, possibly dementia. So tell me about that, because that's all over TikTok and Instagram.
Correct. So that's why definitions are important. So the timing hypothesis, and that was where the new data reanalyzed came out about 2 years ago. Women in that early transition, you're exactly on point, have a different risk assessment than women later in their 70s.
But it still can help women later in their 70s, correct?
Depending on what we're talking about. So that's why the data is evolving.
And it's so individualized.
Correct.
It's so individualized.
So when we break it down a little bit, when we're looking at what were women given in that first WHI study, it was combined equine estrogen orally. So a naturally occurring estrogen
orally, because now you don't take estrogen orally.
Correct. So that's why the definitions are so important, because it was different.
Okay.
And this was estrogen they actually excreted from pregnant horses.
Oh, the what was it called?
Premarin.
Premarin. Okay. Because Dana always talks about it, that one of her aunts was on Premarin and always looked
amazing.
Amazing.
So that is a naturally occurring estrogen in a horse.
So what the hell happened to that? Is it still a thing?
It's still a thing. It's still available, but this is what was used in that first study.
Okay.
The other progestogen, that's the overall term, was a synthetically altered version of progesterone, which your body naturally makes.
Oh my God, it's so confusing. I can't.
But that's why what you guys are doing and putting it out there is so important. They're different. So what they said is for the equine estrogen and the synthetic progestogen from the WHI, women in that early transition had less cardiovascular disease, less all-cause mortality, and if they were on, and now it gets even more levels, estrogen alone, less breast cancer. These were equine estrogen, synthetic progesterones, and that's why when we compare some of the stuff we're doing now, it's not comparing the exact same thing.
Okay. All right, so we have to dumb it down.
We're gonna say
I don't know if she's capable of that. I really don't.
No, your audience is smart.
I know,
smart.
but you have to dumb it down for me.
No, we're gonna say it's not the same. It's not exactly the same. It's a variation. But to that point, starting earlier right now, the better. The conversations earlier, the better.
Okay, so earlier, when I say earlier, I mean 38, 40, like you should start the conversation.
Conversations doesn't mean you're going to start your hormone therapy.
Conversations.
But talk about what your things are, what's happening. And that's why when we're talking about that long-term data, it's not comparing the exact same things that were studied, which was a good powered study from decades ago.
Okay. So talk about someone that, let's say someone is 45 years old.
Okay.
They have their period. It's not irregular, but they are feeling completely out of whack. What would be the first thing you might try with them? If you have your period still, can you go on hormone replacement therapy?
Yes. And I want to put two asterisks to that, because if there's a consideration of conception versus not conception versus birth control, if somebody doesn't want to get pregnant at 45.
Somebody doesn't want to get pregnant at 45 years old. Their hormones are going crazy. They're getting hot flashes. Their mood swings are out of control. They can't sleep. What are you doing?
So first I'm doing an assessment of what other things could be going on, right? Because we don't want to just dismiss and say, oh, it's just perimenopause.
Right.
So once we've gotten a health history, then I think, are you a good candidate for quote unquote the birth control pill? Do you need that contraceptive protection? And are there other things in your life, blood pressure, diabetes, that would tell me that you should not be on birth control? Or would you be a great candidate for hormone therapy? Now it's a lot of nuances because the doses, now I'm going to make it even more wild, that are in contraceptive pills, patches, and rings are higher and different than what is in the hormone therapy, the quote unquote HRT.
Wow. That's wild.
Correct.
Wild.
And they did it because your naturally occurring estrogens and progesterone don't stop ovulation. I'm going to say it again. Wild. So the naturally occurring estradiol and progesterone that your body's making in a cyclic way and then spacing out does not have the strength to stop your brain from having ovulation cycles. So for that 45-year-old, if you're going on hormone therapy dosing, you may still get a period, but those other symptoms may start to feel an improvement.
Okay. So what is the ratio that you've seen that women that go on birth control at 45 feel better? I mean, is it something that is it a regular thing that people do?
People regularly go on hormones for multiple reasons.
And excuse me, didn't you say that was synthetic and that the progesterone that I'm taking is bioidentical? What is the difference?
So it's a great question. So when we're talking about stopping ovulation, the progestogen, we think of that as the main term, has been altered chemically to be potent enough to tell your brain not to ovulate. The same thing with the estrogen and the estrogen dosing. Okay. So you're on something that your body naturally makes, the same structure, the same chemical with the HRT.
Right.
For the contraceptive, it's different.
Why?
because it tells your brain, I'm strong enough, don't ovulate. That's how it's successful. Hormone therapy, because it's mostly for women in that later transition of life that don't need as much suppression of ovulation.
Okay.
But if you're still ovulating and you don't want to get pregnant, the conversation must be had, especially in that reproductive time frame. Are you a good candidate for symptoms based on needs for contraception or not? It's a lot of variables.
Okay. So let's take, I'm going to use myself as an example.
Okay. I love that for you.
So first of all, I want to say that I was kicked out of my gynecologist's office because I did not go regularly.
Okay.
And he had said to me, I've never had a patient, die of breast cancer or die of whatever he was saying. I don't want to start now. I want to see you on a yearly basis, or I don't want you as a patient. And sent me a letter dismissing me from his practice. Okay? Have you ever heard of that?
That is...
I'm not going to say who it was, but
nuanced,
he dismissed me.
And not my style.
Right. Okay. So when I finally had my first telehealth visit with you, I had been feeling so shitty for like 2 or 3 years. And I kept going to the doctor saying, something is not right. It's not me. I'm not feeling like myself. I can't even tell you. And my daughter's here in the studio, how many times I went in 3 years to the emergency room with an anxiety attack. And I knew I was dying at that time. I said, guys, I'm going to die today and you need to take me to the hospital. It got so bad and it happened so often that one time she said to my husband, as he was taking me to the hospital, could you just drop me off at the movie theater, please? Because I have to go to see the movie with my friends. I swear. That's how, Sophia, right? Yeah. So it was so bad.
That maybe to an 11 level.
Yeah.
But the palpitations, the anxiety, that becomes part of the stuff that we've talked about before, just being dismissed. Your hormones are changing so dramatically. It's actually more significantly altered than a younger person going through adolescence.
Oh my gosh, it was so crazy.
And that's why blood levels don't help. That's why tracking cycles are not enough, because it's so erratic.
Right.
And so you're getting to a point you're going to ovulate. Oh my God, my estrogen is up and it crashes. You feel awful. Mm-hmm. And so that balancing, whether we go the contraceptive dose route or the hormone therapy route, gives that gentle hum that helps with those symptoms. So the initial thing you brought up, I don't feel good, all the list of things, hormonal interventions for people can be very helpful.
Yeah. I mean, the anxiety, I'm not an anxious person. That's just not my personality. So when this started happening to me, it was upsetting me to the core because I'm like, who is this person that is, I literally in my brain, I knew I was dying. I knew at that moment when this anxiety attack was coming on, this is it, I'm dying. I even said to my daughter one time, this is after she asked me to go to the movies when I was
Hope it was a good movie.
Yeah. I said to her, I'm like, listen, I'm going to go to the hospital because I'm having a major anxiety attack. I'm going to call 911 right now. She's like, Mom, I will take you. The hospital is 3 blocks away. I said, I don't want to die in your car. I don't want to die in your car. I don't want you to have that on you. I have to get in the ambulance. I swear to God. Sophia, right?
Yeah, so I had to follow her, but I was in my car behind the ambulance.
Yeah, she was in the...
And then I have a video of her coming out on a stretcher.
This is what daughters do to their mothers.
God's honest truth. But now I haven't had, in 1 year, I haven't felt anxious. I haven't, nothing, not even a glimpse of it.
Because it's all connected. Your vascular changes, your mood, your sleep, it's all connected.
Yeah.
And so putting it together is where we need to meet you and all patients.
Right. And let's talk about what does the lack of sleep do to a person, okay, in your daily life. Like you think about like torture in war. They keep people up.
Yes.
To just screw with you
Yes.
and just make you just crush you. And so when you think about someone that's not getting the proper sleep, it's the same thing.
It is, and actually there's so much good research coming out that really sleep is one of the core elements that is affecting cardiovascular health, mood, and cognition.
Right.
Because if you're not sleeping, you're fatigued. I mean, there are limits to when pilots can fly for a reason.
Right.
Your brain needs a break. And that's why asking women, how are you sleeping, is so instrumental, because if you're getting woken up by a hot flash, there are hormonal interventions. We're going to get into some of those options. There are non-hormonal interventions. But if you don't talk about it and realize the importance of sleep, all of those other health factors will be impacted. And I want to just go back to, is the bone issue, where localized estrogen is not going to impact bone health. That's a big thing. Your local vaginal vulvar estrogen is not impacting your bone health.
Listen to that again. So if you're using the estradiol cream,
Vaginally,
or using the pellets vaginally, right?
And I want to be cautious with the word pellets, because pellets is a whole
I don't
other.
mean pellets. I mean tablets
or rings.
Excuse me.
Because there's two types of vaginal rings. You are not getting systemic treatment. It's for local issues only.
So local issues meaning?
Vulvar dryness, vaginal dryness, urinary tract infection, dysuria, pain with intercourse. Some benefits too, because it's helping with the musculature, that you're also potentially having less pelvic floor dysfunction. All of these things are extremely beneficial.
Okay, so would you recommend, I mean, obviously the recommendation is that how often do you use that cream?
So the vaginal vulvar estrogen cream twice a week. Mm-hmm. There are some people that use a tiny amount in conjunction with clinical observation, but the dosing that you're going to get through your insurances or prescriptions is twice a week use.
Okay, and let me show you what that looks like in my little bag of tricks.
I love it. The goodies.
Okay, so this, can you see this?
Yes. It is estradiol vaginal cream.
Yes. So this can be used twice a week. And then how do you apply this?
So there's applicators. So this is something that will go in a measured dose. Mm-hmm. And sometimes what I do is I have patients put half of it on the outside and half of it on the inside, depending on their symptoms, because your body will absorb it. So when you take your tube, you put it in an applicator, and then that's the amount you use twice a week. Okay, or once a week.
So how much would you use of this? Just a little?
It should go into a applicator.
So it'll give you the dosage.
Correct.
Okay. So it's funny because I use this on my face. And I have been using this on my face for the last, I would say 3 months.
Okay.
3 to 4 months. Now in Europe, they've been using estradiol on their face for years. And it has been approved for thickening the skin on the face. What do you think about that? I know you have to be cautious with what you say, but...
Well, we're going to talk about evidence. So there are different types of estrogens, just like we talked about the different progestogens. The estradiol is what your body naturally made. And some of the newer creams, and this was even a session at the Menopause Society meeting, estriol, which is a less potent type of
like
estrogen.
0.03, right? And Alloy has that too, right?
So there are different companies that are using it. So what's interesting is that, will it help thicken tissue? The research is suggesting yes. But is that giving you the wanted results? Because a lot of the bags or tension is really more related to lymphatic drainage, and hyaluronic acid could be more helpful for the hydration component, because some of these creams are coming with multiple things in it. So when you're pulling apart the research, and I think you and I had talked a little bit about this, is it the estrogen or estrogen type component, or is it more related to the hydration? So that's yet to be determined of what the best thing is. And then how do you determine how much are you putting, just a little bit? Are you putting it everywhere? And what will be the level of absorption if you're putting it across a bigger surface area?
Right.
So that's where we don't have the data, but a small amount, is it really the estrogen or estrogen type, or is it more the hydration component? So I say the jury's still out on that one.
Okay. I mean, I feel like it's done something for me, but I do so much to my skin. How would I really know?
And that's such a good point, is that when you're putting so many things together, is it A, is it B?
Right.
And
is it the laser I'm doing? Is it some of the treatments that I'm doing with Sharon at
Correct.
Women in Touch Cosmetics?
Absolutely.
Is it the Meadow and Bark products I'm using? I don't know. Is it just the fact that I'm on hormone replacement therapy in general? So I don't know.
That probably,
But there have been studies that say that this does help.
because it changes the texture and the thickness of
Right.
the skin.
For sure.
Will that though get rid of bags and swelling?
I don't know about that.
Right.
Yeah.
So we say that if it's something that is working and a small amount, because again, the surface area is what we don't know how much is getting absorbed.
Right.
But for people that are already on systemic estrogen, are you really going to get a huge shift in those levels in a negative way when you're already on a progestogen? I know we're going to talk about that. So more to come.
More to come, more to come,
More to come.
So the next thing I'm on is the progesterone.
Progesterone.
All right. 100 milligrams
Every night.
every night. Just one capsule every night.
Correct.
Okay.
Now, this is where more is not better necessarily, because I have people that get different doses of progesterone.
How come some people are on 200, 300?
So the progesterone...
I'm only on 100.
I know, because we're following good guidelines.
She does follow good.
I do. We're following guidelines. It depends on how you're taking it. So the progesterone, like we said, is what your body naturally made. The one caveat for this specific is that if you have a peanut allergy, you cannot take this version of the progesterone.
Okay.
Okay. What that does is, because you're taking systemic estrogen, so what Ingrid just showed you was local. This is when you're taking systemic estrogen and protects for a woman that has a uterus.
Right. So when you are on an estradiol patch,
Correct.
you need to be taking in conjunction with progesterone, correct?
Correct.
Unless you don't have a uterus?
Correct.
God, I'm so smart.
Yeah, she's wicked smart. So yes, that is correct. So the estradiol patch is
I'm
a
going to show you guys how to use
topical. So at the size of a grape, and you peel it apart and you put it on usually your belly, left, right, hips. I put mine on my belly so I don't forget it on the back, because I'd
this.
forget it.
Oh, some people can put it on the back?
On the back over here. So as long as it's getting absorbed, but in the front, usually you get the better absorption. So the estradiol patch is, again, the version of what your ovaries make, and the progesterone the same. And if you have the uterus, you need both. Why are women on higher doses? So sometimes people are not taking it every night. What are the side effects of progesterone? It has a sedative effect. So it's not prescribed for sleep, but people may feel sleepier.
Right. I definitely notice a difference if I forget.
Right. And you're sleeping better. So again, we talked about the importance of sleep. So the progesterone, 100 is enough to balance the uterus for what you're taking systemically. And some people don't do it every night. Some people do 200 for 2 weeks and then take a 2-week hiatus.
Oh, wow.
So there's different ways in which you can prescribe it, the cyclic versus the non-cyclic. But I find that nightly, which gives that sedative side effect, has been the most effective, becomes part of your routine, like your beauty routine, and has more benefits overall.
Yeah.
And you don't forget.
I'll tell you, my nightstand, I don't know about you guys, but I'm gonna take a picture of my nightstand next
Post
to my
it.
bed and post it, because you will not believe the amount of shit that's on my nightstand.
Sure.
From my creams to my estrogen, my testosterone, my patches. I mean, you name it. It's crazy.
But you feel good. You said
I
it
do.
for a year.
I really do. I feel amazing.
And there's no emergency room visits in the last year.
I'm not dying
We have
in my
success.
daughter's car.
Not today and not tomorrow.
No, exactly.
So why people are going up, the progesterone, so you could get a synthetic progestogen to help balance the uterus with systemic hormone therapy. And the progesterone with the sedative effect, some people go up to help with sleep. Again, it's not prescribed for that.
Right.
And there's some literature and studies saying that the progesterone is actually what limits the benefit of estrogen. So it's a balance. And now kind of going back to that Women's Health Initiative, we're not comparing the same things, but the progesterone combination with estrogen arm did not have as many benefits as the estrogen alone arm. So I want to say that again.
Yeah, say that again.
The estrogen, we know it's a different type than we're giving now, had less complications and more health benefits, cardiovascular, breast cancer reduction, all-cause mortality, than compared to the people taking the progestogen with the estrogen. So the progesterones may not be as beneficial. So increasing that is not something that's overall recommended. And I'd always be curious of why somebody's going up on it.
Okay, but if you have breast cancer, they're saying that you don't need the progesterone, or you do need the progesterone?
So breast cancer, I would say, is a totally different situation. From that WHI study,
Right.
the women with the estrogen only, that oral equine estrogen, had less breast cancer than the women in the estrogen and progesterone arm.
Okay.
So there's something with the effects of progestogens on breast tissue. So giving women more progesterone
It's not good.
we don't know.
Okay.
But in that study with the synthetic version, they had not as many decrease in breast cancer as the estrogen alone. So there was something working together to have less of a benefit.
Okay. It's so confusing.
It is, but I love what you guys are doing because you're talking about it. We'll keep writing it out. I see a lot of posts coming from this now. What is in the study? What is in what you're taking? And why are you increasing the dose?
Right.
And you already answered the question. If you're sleeping and this is protecting your uterus, we're at a good place.
Yeah. So this is protecting your uterus. Tell me about women that are older. Let's talk about women that are older. Let's say the second you have not had your period in 365 days, you're in postmenopause.
You're
correct?
menopausal.
You're menopausal.
Correct.
Okay. And so can you stay on this hormone replacement therapy for the rest of your life?
We don't have the data. We have women that never stopped their hormonal therapy from when the WHI first came out and said, stop, stop, stop. So those women, we have to really look and track what their health outcomes are. But right now, with the combination that we're prescribing, the estradiol patches or pills, or the progesterone in the pill, we don't have that long-term data. So we can't say, stop it at 10 years, stop it at 5.
Because that's all over. The main doctors on menopause are saying you should be on it for the rest of your life.
And that's where we believe as the studies come out, but we don't have a decade because we just really started prescribing it and talking about it within the last few years.
Right.
And then when we say be on it for the rest of your life, is it systemic or is it local? The local estrogen, extremely safe. That's what really precipitates.
So the local, meaning the cream, actually inserted into your vagina.
Correct.
That's what I think people need to understand.
Yes.
The cream, the estradiol cream that came in that tube is
Correct.
safe for most people. Would you agree with that?
100%.
And it goes into your vagina.
Correct. Or even, again, the half-half, outside,
A
inside,
little outside, a little inside.
little combo.
Do a little.
But it helps.
Right. And it helps. And tell us exactly what that helps with.
Again, to go over decrease urinary tract infections. It helps thicken the tissue because the female urethra is smaller. And when the estrogen levels decrease, it becomes thinner. So when that happens, it becomes more susceptible to bacteria. That's how a UTI happens.
Oh, wow. Okay.
Bacteria going backwards.
Wow. Okay.
So if we can strengthen the tissue through the estrogen and make it thicker, it actually will decrease UTIs.
Okay. So this is where I think the confusion lies. I think these doctors saying that women should be on estradiol or estrogen for the rest of their lives, I believe that that's what they're talking about. I believe that.
And for the majority, that really is safe. Again, maybe a very small subset of patients who have gone through specific treatments. But that's why we always want to be careful what we're saying, the systemic versus the local.
Right. And that's why people don't understand the systemic versus the local.
Right. And the systemic, the pill or a patch, can actually potentially be used indefinitely. We just don't have that long-term data.
Right.
For the local,
for now, the local cream in the vagina is the way to go
as
for
needed.
Everybody, as needed.
As needed,
Right.
Indefinitely into your 90s.
Okay.
For the systemic, and that's what I tell patients.
Wait, what did you just say about something getting smaller?
Oh, so your urethra is smaller than a male counterpart, but the tissue.
What do you mean? What do you go back?
Okay. I love anatomy.
Yeah.
So a female urethra, biologic female urethra, is smaller than a male urethra.
What do you mean?
Where the urine comes out of your bladder.
Okay.
So the female urethra, which sits right under the clitoris.
Okay.
So we'll go from top to bottom.
Okay.
Is smaller.
Okay.
It's not as long as some men think some are longer than others, but there's less distance between where bacteria lives on the skin and when there's any stool in the area. So, which always wipe front to back.
Wipe front to back.
Always.
Okay? And that
Just in
helps
general.
with UTIs.
Decreasing where you don't want bacteria to go forward.
Okay.
So as the urethra gets more atrophied or thinner,
Jay, remember that, please.
you always want to then think about if it's getting thinner, and because it's already anatomically smaller than male counterparts, that if it's thinner, will the bacteria have an easier access point to get in? And that's how UTIs are formed.
Okay.
Especially more common.
If your skin is thicker, it won't.
More estrogenized,
Right.
less risk of UTIs.
Okay.
So that's how it helps with that area. And then externally, internally, vaginally, by thickening the tissue. And this is really a good point. And we may have talked about this before. Estrogen makes the tissue thicker. When there's more thickness, lactobacillus, which is yeast, sits there better. So you've got thicker tissue, more yeast, good yeast, and then that holds hydration better. So all of these downstream things improve that GSM, that genital urinary syndrome of menopause. Local treatment, extremely safe, should be used as needed indefinitely.
Okay, so if we're going to talk about local vaginal estrogen, which helps with UTIs, helps thicken the vagina, tell what it does for your sex life.
Aha. So the complexity of sex.
Yeah, let's get into sex.
Dr. Ruth would be so proud of us right now. So your brain is the biggest part of your sex life.
You know what? No one ever says that.
It's true.
Because guess what? Back in the day when the candles were lit and Luther Vandross was on. And
A little Sade.
I'm sorry, Sophia. Yes, exactly. Okay, but that means something.
Correct. Because
Right?
it's the triggers. It's your brain, and the complexity of libido is going to be really
Sophia,
broken.
go into the other room.
Earmuffs. Earmuffs. But it's actually good that we're talking about it, because your relationship, your mood, your mindset, these are large components into your sexual desire and your sex life overall.
Right.
Pain and that pillar is a component of it, where all of this work being done with our menopause champions and our perimenopausal voices is saying, okay, estrogen in this area, take that take that black box warning off, use it, make the tissue feel more
Subtle, supple.
lubricated.
Yeah.
Correct. More
Yeah.
lubricated. And if we can remove that pain component, will then some of that psychologic deterrent be removed, where sex may start to feel better, and it may have that desire. If I said to you, I'm going to take your hand and I'm going to put it on a really hot stove for like a good 15 minutes, you'd be
Right.
like, no, thank you.
Yeah, exactly.
So if
over and over and over again, you're just like, yeah, no.
No, thank you. Right. So you psychologically are saying this is not good. So the pain, the piece as menopause experts, as women's health advocates, we can start to really work on with where a patient needs to be. Mm-hmm. The psychologic component, and there are studies that even look at it. What is the biggest impact on your sex life? Do you even like your partner?
Right. And guess what? That's a whole other episode.
Yes.
Because in hormone replacement therapy and in going through menopause and having all these shifts in your mood swings, if you don't take care of that, some people are, there's been a huge upswing in divorce.
Yes.
And people just not getting along. And when the kids leave the home, these people are off doing their own thing, living their best lives, because they didn't really take care of the situation when it came to the mood swings and really understand what their partner was going through. And I think that, along with kids not even understanding, they don't know, why is mom a crazy lunatic? why is this happening? And they don't take the time to understand. They just don't know it. They're not taught about it.
They're not taught about it, which is why putting it in education, normalizing the terms, but also we talk about menopause.
Right.
We have to make sure our partners are side by side, because when they say it's in our head, well, yes, that's where hormone triggers start. It is in my head,
Right.
but my body could be taken care of in a whole different way. So that sexual piece, that sexual health starts with relationship. It starts with connectivity, and it starts with culture, because I have patients that come in well into their 70s and they're like, we don't have sex anymore. Well, is it a problem in your relationship, or
Maybe
you
not.
guys?
Maybe they're cool. Maybe they're cool with it. They're good.
We don't need to put the focus on one act. It has to be relationship connectivity. That's where the evolution comes,
Right.
not one act.
Right. And I think also I don't know, I'll just say this is just the way I feel, that I feel like a lot of women are programmed to make their partner feel good and don't really accept that sexual pleasure themselves a lot of times.
Well, that's
Right.
culture.
Right. And that's been the culture. It's
Yep.
like, make sure that your husband feels great, make sure that he's intact, and we just fall to the wayside. But now tell us about what's out there for women. Like, there's Viagra for men, there is something called the little pink pill, or there's other things, other ways that women can increase the libido in menopause.
So, and that kind of goes into the complexity of it. It's not a one size fits all type of situation, because it may take many things to really get you to a place where you're enjoying your sex life.
Right.
Because there's desire, there's orgasm, there's the pain component. So currently there are 20 plus medications approved for male sexual dysfunction. There are 2 for women.
2. That's
So
it.
seems even.
Right. That
Fair.
seems fair.
Fair. And they're just for perimenopausal women.
What?
So this is, again, what's FDA approved.
Wait, so if they're used on menopausal women, do they still work?
It's off label,
Okay.
but there may be some benefits, but they're not the same medication. So let's talk about the little blue pill, right? So that changes blood flow patterns, targeting specific areas. So an erection comes from a change in blood flow. So that's where that medication targets. They're using that now topically for women, because if you think about orgasm and sexual experience and desire, it's blood flow patterns to the clitoral region. And there are over 10,000 nerves and nerve endings in the clitoris. Correct. It's a very powerful thing. I think of that Seinfeld, Dolores. It's funny because it's true.
Yeah, this is true.
Vulva.
Mulva, I love that.
So
We need to rewatch.
yeah, it's such a good episode. They're all good episodes.
Right.
So if you think about that, if you're bringing blood flow to that area, that's what you talked about, the candles and the mood setting music.
Right.
Your body is triggering that blood sensation, which is why some topical creams, some devices actually put on the clitoral region bring blood flow. Masturbation, self-exploration brings blood flow to that area. And most of the clitoris, you just see the little hood, a few millimeters, but it will go along your whole pelvic anatomy underneath where your labia majora and the labia minora are. So all of that sensation goes along that area. So stimulation globally can be really impactful.
Globally, I like
Correct.
that. I want to be global.
Yeah, for this, we got to go global. And so the complexity, the blood flow patterns, evolving women's health, where again, not FDA approved to change blood flow, but are there ways that you could start to do that? Yes. And the 2 medications that are FDA approved target neurochemicals in the brain, dopamine, serotonin.
But they're only approved for
perimenopausal women. Doesn't mean things are not used off label.
Right.
And then there's another one that's an injectable that is used as needed.
An injectable.
That is more targeted, again, neurochemical changes related to melatonin.
Okay, question.
Yes.
If a man goes into their doctor and says, I have a low libido, is that considered a medical diagnosis?
Yes.
And same for women.
It should be, and it is a code when we talk about low libido. So that needs to be discussed in depth in terms of their sexual health and going through relationship, depression, physiologic changes. Women that have diabetes have poor blood flow. So this can actually impact their life. Women that have gone through cancer treatment or radiation to the pelvis, that really impacts blood flow and tissue quality. All of these things need to be discussed. Again, Dr. Ruth is so proud of us right now.
So proud. I mean, do you think that men, when they go into a doctor and they're talking about their low sex drive, do you think their doctors go into everything that you're talking about right now? The relationship, doctors just aren't trained the way you are trained. How much training did you get in medical school for this? That's what I want to know.
So a very small percentage, and a lot of what we're doing in the healthcare women's space is because there were gaps, but we're combating that. We're educating students. We'll get there, but I didn't get a lot of this. I didn't get any of this in medical school.
Right. So this is all extracurricular on your part.
Yes, and it is such a gap in care that until we started talking about it and realizing I don't have this long-term information. Have I really asked somebody how their sex life is? Are they having discomfort? How's the libido? If you don't ask, women are not necessarily bringing it up.
Right. That's why I love that you ask. Because in a medical setting, you're more likely to answer that question. It's not like, hey, like no one wants to hear about married sex. Like, I don't want to hear about that. Like when I was 20, I'll tell you everything. Now, I don't want to hear it. But if a doctor asks you, now you can really think about it. Well, hey, how is my sex life? And does it matter to me? Some people, it doesn't matter. Some people, they're cool with it. They could care less about it. But do they not care about it because it's just a low libido issue? And if there was something that could help them, would they care about it again? I don't know. So that's a question too, right?
It's such an important thing because I have a lot of patients that have new partners and their sex life is ignited.
Right.
So they weren't put on any additional hormones. They could if they needed it. But it was that relationship core. They have...
Exactly. That's the core of your relationship.
Correct.
Like I know with my relationship, that's a big deal for us.
Right.
You know what I'm saying? Like that would never not be a big deal.
And that's where you guys are meeting at the right place, the same time. And not everybody has the same needs in their relationship, but also the pain factors and the whole idea that we're actually addressing hormonal therapy is awesome.
Yeah.
And that's where testosterone, more data is coming out. Is it a placebo effect? Is it an actual change? Where women are, and this is one thing that levels in the hormonal space should be checked because
with testosterone. Because when you tested mine, and I'll just admit, say this right, I have nothing, no testosterone.
And then it's about, are we checking the right assays? Because women's testosterone levels are lower than men. Women make their testosterone in their ovaries, in their adrenal glands. So there's multiple ways that a woman is producing it. And then the fact that our levels are lower, you need a very specific assay and you're looking at total levels.
I don't know what that means.
So if you're going in and this
Testosterone for dummies.
Testosterone for dummies. No,
I'm kidding.
Testosterone levels have to be done with a very specific lab evaluation.
Okay, so if you think that your testosterone is low, I would like you to mention a few signs that would indicate that it's low and the blood work you would ask your doctor for.
Love that. So what happens in perimenopause, your testosterone levels once you hit menopause are a little bit more balanced.
Okay.
They're not continuing to drop.
Okay.
That is pretty good studies where we're actually checking levels. The other thing is that there's a little bit of an increase when women are in their 70s. Is it related to a whole combating of other symptoms versus, but this is really...
Are you sure they're just not, understanding that they're not tweezing as much?
It's very possible, but there is a little bump later in their 70s. It does not necessarily correlate to their having these crazy changes in their sexual health,
right?
But that's the levels balance out. So what are the symptoms that you're having? You may have no symptoms because giving testosterone may or may not impact a woman the same. So when you're talking about libido, hair changes, acne, these are things that can be associated with elevated or low testosterone levels. So if you're noticing those things, those would be something to bring up to your provider. And then a mass spectrometry total testosterone testing. Because again, women make testosterone at lower levels than male counterparts. It's a very specific test that can be done for lower levels. So you want to ask for that test to be done.
And what is the name of that test again?
It's a mass spectrometry. It's how the lab runs testosterone when it's produced at a lower level. And you want a total level. That's what we're tracking.
Okay. So this is my testosterone.
Is your T?
This is my T. And basically this is 1 milligram.
So that's where we have to be careful, because if you're getting it compounded, it's going to have a little variation of how they're prescribing it, number of clicks versus not, but it's based on 1/10 of the dose as a cis male. So our male counterparts, when they're given testosterone, women should be given 1/10 of that dose.
Okay. So basically all you do is you twist this, the cream comes up, and then you put it, wherever you put it. You can put it on your inner thighs. You can put it on your
Behind your thighs, back of your shoulders,
on
your
your
arm.
hips, wherever. I mean, I'm going to just put this on here right now.
It's fine.
Now, they do warn you that there are some instances where you can maybe grow hair,
Correct.
lose hair, but I'm Italian, so I am accustomed to the hair, okay? Not a problem for me. I've been shaving since I'm 12.
This is where the cosmetic piece
Exactly.
and self-care.
Yeah.
But again, that's where we have to be cautious that when things are compounded, we want to use a reputable place.
Right. So I use Precision Pharmacy, but they're amazing. But the one thing that I did ask Dr. Kelly Casperson when I went to, we had like a little talk back with like 20 people in Times Square a couple of months ago. I said, my nightly routine consists of my estrogen cream on my face, my estrogen cream in my vagina, my testosterone on,
My patches, my progesterone.
It's crazy. I said, is there an effect? Like no one tells you in which order to put them on. So I was afraid. I was asking her if I did put my estrogen on my face or put this on my hip first, right? And then I put the estrogen on my face. Is there a chance that I'm putting testosterone like a little bit left over on my face?
Did she tell you to wash your hands well before?
Yeah.
Correct. Because
But I didn't know that. And I was, that's why I asked the question. I'm like, could it be?
the testosterone can be a little bit more potent. So definitely want to wash your hands.
Right.
The order of operations doesn't matter.
Right. The order of operations doesn't matter.
It doesn't matter.
You do want to be careful when you're...
Correct. And that's why, again...
Especially if you're Irish and you're not used to the hair that the Italians are used to.
So I'm Italian and Irish, so I get it. And that's why when people say, how many clicks, how many this is where the levels are more for negative potential side effects, because the testosterone use in women's health is more globally used at this point.
Right.
Different countries like Australia, there are formulations that are approved. So that's shout out to other countries that are a little bit ahead.
Why are we always so behind? Can you please tell me?
I think I will refrain from that comment.
I don't understand when I research different, like the estradiol, for instance, on your face. They've been using it for 20, 30 years.
Australia is hugely facing
and then the
forward.
Koreans. Mm-hmm. I don't even want to get into the Koreans with the skincare.
So
I mean, you could eat sushi off their cheek pads at 65 years old.
The combination.
By the way, you have great fat pads on your face.
Thanks.
They're beautiful.
Fat everywhere. It's all okay.
No. They're very,
very full.
love them.
But I think that's why also the testosterone and the dosing really is going to be something that's evolving until we have an FDA regulated, because compounded pharmacies are not regulated. So you have to really trust in what they're using as the agent to break it down.
So that is a really good point. You really need to make sure that you have a trusted compounded pharmacy.
Correct.
You can't just use, your Alibaba.
Correct.
pharmacy.
Or
that's not happening.
No, you have to be really cautious. The doses can vary because it's not regulated. And 1 click, 4 clicks, this is why we track the levels, because the negative side effects, and there's studies ongoing looking at irreversible voice changes, the clitoris enlarging and not in a good way during.
You're going to get a piece of deal.
So there's
no good.
No hair changes, hair growth, hair loss. So these are when your levels are getting to a more male set
But
point.
I mean, I'm sure you would know that in advance. Like if you see that you're gaining, you're getting a penis.
Well,
wouldn't you say, hey,
one would hope.
I'm gonna slow down.
One would hope. But sometimes people feel so different and you feel so quote unquote good that the other side effects are suppressed.
Right.
So that's where the levels tracking.
It's all what is important to you.
Correct.
Right?
It always is.
Yeah. Like I say that about my GLP-1.
Yep.
Right. I am microdosing it, and I feel that I don't want to lose any weight. I use it for inflammation. It makes me feel amazing.
Yep.
And I also think that when you have a problem with food, it's not, using a GLP-1 is not the easy way out. And when people say that, it makes me so angry, because just like someone would be an alcoholic or a drug addict, or maybe not have the right regulatory system in their body to lose the weight. I think it's such BS when people say you need to work at it and you really need to lose weight the right way. That is total BS, because all my life I've worked out 5 days a week consistently. I eat well. So when you get into menopause and you see that what you're doing, what you've done all your life, being healthy, working out, just isn't working anymore, and that this works. I mean, like I've said before, you could take my hand before you could take my GLP-1, just because I feel so good.
And that's your experience, which is so important, because everybody's experiences are going to be different and unique, but you're also doing the balance of the micro and macronutrients. You are doing weightlifting,
right,
because you're losing.
You're 100% right. So when it comes to the GLP-1, the way that I'm taking it, when people say, oh my gosh, this person has Ozempic face, or they lost, all this weight. If you are not doing a regular, under a supervised care, you shouldn't be losing more than 2 pounds a week. And the reason why people get Ozempic face is because they're losing 10, 20 pounds a month. It's just not normal. So even if you were losing weight using whatever method it was, it doesn't matter. The rapid weight loss causes that Ozempic face.
You're absolutely right. It's the combination of what you're doing, and there are really significant hormonal shifts when you are in menopause. The hormone
is a GLP-1 a hormone?
So hormones are a global term of it. It regulates how our body is interacting. So directly, is it a hormone like estrogen? No, it's not a sex hormone, a sex steroid, but it interacts with all of those components. And what they're doing is they're telling your body when in menopause, your hormone levels that make you feel full are going down, and your hormone levels of food that are telling you that you're hungry are going up. It actually helps regulate those neurochemical balances in metabolism.
Right. Yeah. I mean, and the studies are showing that it actually can help people with addiction. It can help people with, obviously, with obesity, which, you have to take 6 of one, half a dozen of the other, really, for any downfalls that you think that this medication may have. And I can't use the O word because it's not, some people will say Ozempic, GLP-1, it's the same thing, right?
Well, and that's where, again, definitions matter. There are oral medications. They're going to move a GLP-1 to an oral formulation. And the different types of the GLP-1s that are interacting with that metabolism factor have different targeted weight loss values. So some of them, you're going to look for 40 pounds, while some other ones are going to give you about a 10 pound, and there are non-responders. So not everybody is going to have the most amazing change in their weight based on these medications.
Okay.
So there's different types, different targeted weight loss values associated with them, different side effect profiles. So it's a matter of what the goal is for the patient and which one you'd potentially start on.
Right, because I feel like even when I started my GLP-1 in the beginning, even the smallest dose was, I was nauseous. I was sick to my stomach. I felt awful. But using even the smallest dose of the smallest dose is amazing. And I think that more people should look into microdosing the GLP-1.
Well, and that's where the data is evolving.
Right.
And so to tell somebody, no. I mean, I have patients that have high blood pressure, diabetes, that have an elevated BMI and are fighting to get it covered. It is so beneficial for them to be on medications for multiple reasons. But that's where, again, where is this whole space for women's health going? How are we controlling that metabolic factor? Because these are all, yes, hormones, and how we're suppressing and increasing all a new phase of medicine.
Yeah. And I really would like to I know we have to wrap it up, Jay. I really would like to address GLP-1s in younger people that don't need to lose weight. It infuriates me. They're getting this shit online.
Yep.
You don't know where the hell you're getting it from.
Right.
You're not working out. You're sitting there scrolling on your phone.
Right.
And what are you doing to your body? You have to work out. You have to lift weights. If you're going to be on this, it has to be because you need to lose weight or you have an inflammatory. You have to have some kind of issue instead of wanting to look like a skinny little, runway crackhead model. Like I'm dead serious. And I know a lot of younger women that are on it, and it's so bad for you if you're not eating the right protein and having the fiber and drinking water and working out and doing all the things that you need to do to be healthy on it.
And that is the key. It's the health span, because it's not just about your absolute weight.
Yeah.
It's about how healthy you are. And that image is got to change, where it's not the focus on skinny, because skinny doesn't mean healthy.
Right. Right. And I do think that that's changing in menopause. I do think that a lot more women are lifting weights. The cardio that we used to do, running until we, our feet fell off, that's kind of out the window. I mean, cardio is still good for you, but I do believe that more women are leaning more towards weightlifting.
Yes.
And not pounding their bodies like they used to with cardio.
Right. I did 2 chin-ups and I could cry. I know. I love that for me.
Oh my God, congratulations. That's amazing. Yes. No, that is a big deal.
Right. Because that's about the healthy living.
Yes. Yeah. Oh, I'm so happy
2.
for you.
That's it. Maybe next time I come back, I'll be up to 3.
All right. On that note, we are wrapping it up with the chin-ups, but we'll be
Not
back.
chin hair.
No chin-ups, no chin hair.
That'll be our hashtag for this episode.
All right, guys. Thank you so much for watching. Remember to click the subscribe button, and we'll see you next time on Rebranding Menopause Podcast.